One morning, my wife called me at my clinic and said, "Something is wrong with my father." He had been taking ibuprofen every day for 2 years, not prescribed, just over the counter, available at any convenience store in Japan, in America, everywhere. He bought it himself, took it himself, never mentioned it to anyone because, in his mind, it was not a real medication. It was just something you take, like tea, like vitamins. By the time we got the scope results back, he had a bleeding ulcer in his stomach the size of my thumbnail. I have been a practicing physician for 31 years. I have seen this happen more times than I want to count, and every single time, the patient says the same thing. "But I thought it was safe. I've been taking it for years." That phrase, "I've been taking it for years," is the most dangerous sentence in medicine. Because duration is not the same as safety. Time passing does not mean damage is not accumulating. It just means the damage has had more time to build quietly, in the dark, where no one is looking. Today, I want to talk about 3 common pills. Pills that millions of people take every day. Pills that are genuinely helpful. I am not here to tell you to throw them away, but pills that have a side that most people never hear about because no one explains it to them. Not the pharmacist, not the label, not the commercial. And what I found when I looked into all 3 of them, carefully, with 30 years of context, I wish someone had told me sooner. Let us start with the one that almost took my father-in-law from us. NSAIDs, non-steroidal anti-inflammatory drugs. You know these by their first names: ibuprofen, naproxen, aspirin in higher doses, diclofenac. They are, without question, some of the most useful medications ever developed. For arthritis, for joint pain, for back pain, for post-surgical inflammation, they work. I prescribe them. I have taken them myself. I am not standing here to condemn them. But here is what most people do not understand about how they work. When you swallow an NSAID, it does not just go to your knee or your hip or wherever it hurts. It goes everywhere. It travels through your entire bloodstream. And one of the things it does, everywhere, not just at the site of pain, is block a family of enzymes called COX enzymes, COX-1 and COX-2. Blocking COX-2 is where the anti-inflammatory effect comes from. That is the good part. That is the part that helps your joints. But COX-1 is different. COX-1 is responsible for producing a substance called prostaglandin, and prostaglandin does something very specific in your stomach. It tells your stomach lining to protect itself. It stimulates mucus production. It maintains the barrier between your stomach's acid and the cells underneath. It keeps the walls of your stomach alive. When you block COX-1, which most traditional NSAIDs do because they are not perfectly selective, you are not just reducing pain. You are pulling away the stomach's defense system. Every single day you take that pill, your stomach lining becomes slightly more vulnerable. The acid that is always there, that your stomach produces as a normal part of digestion, starts touching surfaces it is not supposed to touch. For some people, this happens fast, within weeks. For others, it takes months. For my father-in-law, it took 2 years of daily use before the bleeding started. And here is the part that stops me every time I explain this to a patient. There is often no warning, no pain, no nausea, no signal that something is wrong. Stomach ulcers caused by NSAIDs are called silent ulcers because the same medication that is reducing your pain in your joints is also reducing your ability to feel pain in your gut. The ibuprofen that numbed your knee also numbed the early warning signs in your stomach. By the time you feel something, the damage is already significant. The statistics on this are not gentle. People who take NSAIDs daily have roughly 3 to 5 times the risk of developing a serious gastrointestinal complication compared to people who do not. And we are not talking about rare populations here. We are talking about the millions of older adults who have chronic joint pain, who reach for ibuprofen or naproxen the same way they reach for their morning coffee, because it helps, because it works, because it is available without a prescription, and therefore feels harmless. If you are taking an NSAID regularly, and by regularly I mean more than a few days a week, more than occasionally, please talk to a doctor about two things. First, whether a COX-2 selective inhibitor might be appropriate for you instead. These are more targeted. They block COX-2 more specifically, which means less impact on that protective COX-1 pathway. They are not perfect, and they have their own cardiovascular considerations, but for the stomach, they are meaningfully gentler. Second, whether you should be taking a proton pump inhibitor alongside, something to reduce acid production and protect the lining while you are on the NSAID. This is called co-therapy. It is standard practice in Japan for patients with arthritis who require long-term NSAID use. In many other countries, it is underprescribed. What happened to my father-in-law, by the way? He recovered. 6 weeks of medication, dietary changes, no more over-the-counter ibuprofen. His doctor switched him to a different approach for his knee pain. He is still stubborn. He is still farming. But for a few weeks that spring, it was very close. Now let me tell you about the second pill. This one is harder to talk about because it is associated with something people feel very hopeful about. Bone health, bisphosphonates, alendronate, risdronate, ibandronate, zoledronic acid. If you or someone you love has been diagnosed with osteoporosis, weak bones, high fracture risk, there is a reasonable chance a bisphosphonate has been prescribed. They are the most commonly prescribed medications for osteoporosis worldwide. And they do work. They reduce fracture risk in the spine and hip, which are the fractures that most devastate the quality of life in older people. I have patients alive and walking today because they took these medications at the right time. But bisphosphonates are a class of drug where the mechanism is almost poetic in how it creates its side effect. Here is how they work on bone. Your skeleton is not static. It is constantly being broken down and rebuilt. There are cells called osteoclasts that dissolve old bone tissue, and cells called osteoblasts that build new bone. Bisphosphonates work by poisoning the osteoclasts, not gently discouraging them, actually disrupting their function so profoundly that they undergo apoptosis, which is a kind of programmed self-destruction. With the osteoclasts suppressed, bone breakdown slows, bone density improves, fracture risk decreases. This sounds ideal, and for a certain window of time, it is. But here is what happens when you extend that suppression for years and years. The osteoclasts also serve a maintenance function. They are not just breaking down bone randomly, they are targeting old, damaged, fatigued bone tissue. Microfractures accumulate in bone over time from ordinary daily stress. The osteoclast system is how the body finds and removes that damaged material, so osteoblasts can replace it with new, stronger tissue. When you suppress osteoclasts for too long, that maintenance cycle slows down. Old, brittle, microcracked bone tissue is not being cleared away. It is just sitting there, accumulating. And so you can end up with a bone that has higher measured density, but paradoxically, poorer quality. Higher mineral content, more microdamage retained. This is the mechanism behind what is now called atypical femoral fracture, a rare but devastating complication where the femur, the large thigh bone, fractures in an unusual location, often with little or no trauma, sometimes with a brief prodromal period of thigh pain that is dismissed or misunderstood. These fractures do not look like ordinary osteoporotic fractures. They occur in a different part of the bone. They are transverse rather than oblique. Some patients describe a dull ache in the thigh for weeks before the bone simply gives way. And because bisphosphonates are prescribed for fracture prevention, there is a terrible irony in this. Patients who took the medication faithfully to protect their bones experience a fracture that the medication itself may have contributed to. Let me be very precise about risk here, because I do not want you to panic. Atypical femoral fractures are rare in absolute terms, somewhere in the range of 1 to 100 cases per 100,000 person-years of bisphosphonate use. The fractures that bisphosphonates prevent, hip and spine fractures, are far more common and far more likely to occur if osteoporosis is untreated. For most patients, especially in the first 3 to 5 years of treatment, the benefit clearly outweighs this risk. The issue arises with very long-term use, beyond 5 years, beyond 7 years, beyond 10 years. And there are patients who have been on these medications for 15 years because no one has reassessed whether they still need them. Many major guidelines now recommend what is called a drug holiday, a pause in bisphosphonate therapy after several years of use, allowing the bone remodeling cycle to partly recover before reassessing whether treatment should resume. There is also a second gastrointestinal issue with oral bisphosphonates, the esophageal one, that is distinct from the femur story but worth knowing. These pills are highly acidic and caustic to soft tissue. If they sit in the esophagus rather than passing quickly into the stomach, they can cause esophageal erosions, ulcers, and in rare cases, esophageal stricture. This is why every bisphosphonate prescription comes with instructions to take the pill first thing in the morning with a full glass of water, remain upright for at least 30 minutes, and not eat or lie down. These are not arbitrary rules. They are the difference between the pill reaching your stomach safely and the pill burning through tissue on the way down. My aunt, my mother's younger sister, has been on alendronate for 9 years. When I visited her last New Year and she mentioned her thigh had felt a little strange for 2 months, I felt something drop in my chest. I sent her to a colleague immediately. Her bone scan was normal. The ache resolved on its own. We are watching closely, and her doctor has begun discussing a drug holiday. But if she had not mentioned it, if she had just assumed it was normal aging, it might have taken longer to catch. Most patients do not know that unexplained thigh pain while on a long-term bisphosphonate is a red flag. Most patients were never told. Now, the third pill. This one is in almost every older adult's medicine cabinet in the world. It is not for joints directly, but it is taken by many people who are also managing joint and bone conditions because the underlying health picture overlaps. I am talking about proton pump inhibitors, PPIs, omeprazole, pantoprazole, lansoprazole, esomeprazole. There is a particular irony here that I find almost elegant in how circular it is. I just told you that one treatment for protecting your stomach while on NSAIDs is to add a PPI. And now I am going to tell you that long-term PPI use has its own separate risks, including one that directly affects bone. PPIs reduce the production of stomach acid dramatically. That is precisely what makes them useful. Acid reflux, GERD, esophagitis, peptic ulcers. These are all conditions where too much acid is causing damage, and PPIs intervene powerfully and effectively. For short-term treatment, and for specific long-term indications like Barrett's esophagus or documented severe reflux disease, they are appropriate and well-supported. The problem is that PPIs became one of the most overprescribed drug classes in modern medicine. Not because doctors are careless, but because they work so well and feel so benign. A patient comes in with heartburn. A PPI is started. The heartburn resolves. The patient never stops taking the pill because stopping it causes a rebound. Acid secretion temporarily surges when PPIs are withdrawn, which can make symptoms return worse than before, which leads the patient to conclude they need the pill indefinitely. This cycle traps millions of people in long-term PPI use that was never clinically intended. And the long-term effects are real, documented, and still not widely known by patients. The first one connects directly to the bone story I just told you. Calcium, the mineral that your bones are literally made of, requires acid in the stomach to be properly absorbed. Specifically, calcium carbonate, the most common form in supplements and fortified foods, needs an acidic environment to be broken down and released into a form the intestine can absorb. When you suppress stomach acid profoundly and consistently with a PPI, calcium absorption decreases. Studies show that long-term PPI users have lower bone mineral density and, this is the important part, significantly higher rates of hip, wrist, and spine fractures. We are talking about a 30 to 40% increase in hip fracture risk in some studies of long-term high-dose PPI use. Think about that for a moment. A patient takes NSAIDs for arthritis, is started on a PPI to protect the stomach, and the PPI then slowly undermines calcium absorption and increases the very fracture risk that the arthritis specialist is trying to manage. These systems do not communicate with each other the way they should. The gastroenterologist prescribing the PPI is not always talking to the rheumatologist managing the joint disease. The patient is caught in the middle, taking medications whose interactions no one has fully mapped. The second long-term risk of PPIs involves magnesium. Magnesium is absorbed in the small intestine through a process that, like calcium, is partially dependent on the acid environment in the preceding stomach. Long-term PPI use is associated with hypomagnesemia, low magnesium levels, and magnesium is involved in hundreds of enzymatic processes in the body. Muscle cramps, fatigue, irregular heartbeat, neurological symptoms, these can all be downstream effects of magnesium depletion. And because the symptoms are vague and common in older adults for a dozen other reasons, the PPI connection is rarely made. The third risk is one that still generates some scientific debate, but the evidence has become difficult to dismiss: an association between long-term PPI use and increased risk of chronic kidney disease. The mechanism is not fully understood, but multiple large population studies have now found the signal, and the hypothesis involves inflammatory processes triggered in the kidney by PPI metabolites over time. I am not saying PPIs are bad medications. I am saying that they were designed for specific, often time-limited use cases, and they are being used chronically, without regular reassessment, by an enormous number of people who may not still need them. The question every long-term PPI user should bring to their doctor, and I mean this as a direct request, not a suggestion, is, do I still need this dose at this frequency indefinitely? Or is it time to try a supervised taper? There are often alternatives: dietary modification, H2 blockers which are gentler and have fewer long-term concerns, sleeping position changes for nighttime reflux, weight management. These do not work for everyone, but they have not always been seriously tried because the PPI worked immediately and the alternatives require more effort. Here is something I want you to understand about why this happens, why patients end up in these situations. It is not because doctors are negligent. Most of the time, it is because medicine happens in episodes. You see a doctor for a specific complaint. They treat that complaint. Months pass, a year passes. The medication continues because stopping it was never a specific item on anyone's agenda. No one is assigned the job of looking at the full picture. Every pill you take, every month you have been taking it, every interaction between them, and asking, does all of this still make sense? In Japan, we have a concept that roughly translates as polypharmacy awareness, a growing movement within geriatric medicine to sit down with older patients and their complete medication lists and simply ask, is all of this necessary? Studies show that a meaningful percentage of older adults are taking at least one medication that is no longer needed, that is interacting negatively with another medication, or that was started for a condition that has since resolved or changed. And yet the prescription was never revisited. My own mother, I tell this story not for sympathy, but because it is true and because it changed how I practice. My mother was on 6 medications when she was 71. Her general practitioner, her cardiologist, and her orthopedist each knew about their own piece. No one knew about all 6 together. One of those 6 was a high-dose NSAID for her hip. One was a PPI started to offset the NSAID, and her bone density tests were deteriorating in a way her orthopedist found puzzling because she was already on a calcium supplement. It was not puzzling once I looked at it together. The PPI was reducing her ability to absorb the calcium she was faithfully taking every day. The calcium supplement she believed was protecting her bones was being partially neutralized by the stomach acid suppressor that was protecting her stomach from the joint medication. She was doing everything right, individually. The system was failing her. I had her switch to calcium citrate, a form of calcium that does not require an acidic environment for absorption, which makes it appropriate for people on PPIs. I worked with her doctors to reduce the NSAID dose and frequency and explore other pain management strategies. We did a supervised PPI taper and moved to a lower dose on alternate days. Her bone density stabilized. Her magnesium levels normalized. She is 79 now. She still has hip pain. She manages it differently. She knows more about her medications than she ever did before, because I finally sat down and explained them to her. Really explained them, instead of assuming she did not need to understand. That is the other failure I want to name plainly. Patients are often not told enough, not because of malice, but because clinical time is limited, because medical language is intimidating, because we assume patients do not want the complexity. But they do. They want to understand what is happening inside their own body. They want to know the trade-offs. They want to make informed decisions. Every patient who came to me after my mother, I changed how I talk to them. I sit with them longer. I use plain words. I ask them to tell me back what they understood, because information, given clearly and with care, is itself a form of protection. So let me leave you with something concrete, not a list of rules, because I do not find rules stay with people. An image. Think of your body as a house, and think of every long-term medication as a renovation. Some renovations are necessary, they fix something real, but every renovation changes the structure slightly. And if you do renovations in different rooms without a single architect overseeing the whole house, if the electrician does not talk to the plumber, if the person fixing the roof does not know what is happening with the foundation, eventually something unexpected fails. Not because any single renovation was wrong, but because no one was watching the whole picture. You deserve someone watching the whole picture. If you do not currently have a doctor, one doctor, even a general practitioner, who knows every medication you take and has reviewed that list in the last year, that is the thing to address, before any other health concern. Not because everything is wrong, but because understanding your own medication landscape is the first and most basic form of self-protection available to you. NSAIDs for your joints, powerful, real benefit, real gastrointestinal risk, manageable with the right knowledge. Bisphosphonates for your bones, meaningful protection against fracture, a different risk with very long-term use, addressable with a drug holiday and monitoring. PPIs for your stomach, excellent for their intended purpose, commonly used beyond it, with downstream effects on bone density, magnesium, and possibly kidney function that almost no one mentions at the pharmacy counter. None of these are villains. All of them are tools. Tools require instruction, and instruction is what most patients never received. My father-in-law is well. My aunt is being watched carefully. My mother is 79 and still complaining about my cooking when I visit, which I consider the best possible health indicator. Go check on your medications. Bring your list to your next appointment. Ask the questions you were never told to ask. And if a doctor brushes you off, if they do not have the time or the patience to explain what you are taking and why, consider whether that is the right doctor for you. 31 years in medicine. The patients I worry about most are not the ones with the most complex diagnoses. They are the ones quietly taking the same pills they were handed years ago, assuming that because no alarm has sounded, everything must be fine. The alarm does not always sound early. That is the whole problem.